Okay, so what we're trying to do is tape every CASA Cafe, so if you miss it, you can see it on our YouTube channel and you would still get your hour credit. You just need to let us know you did it.
Wait a minute. What do you mean your YouTube channel?
I'll send you the link.
Do you know their YouTube channel?
Well, okay, so anyway, before we get started, I wanted to introduce Amy Faulkner, who some of you may know. She was our program director for, did we say 6 or 7 years, Amy?
About 7 years.
About 7 years, so she's come back as our training manager. Finally, her last little girl is what, in pre-K? Okay, so she has a little more time. So she's here part-time with us. We're very excited. And in the back, Ruby, if you'll just wave your hand. This is Ruby Harris. She started with us as program manager, doing all the intake of new cases, sending out all the early family engagement volunteers, and just really going to be a great part of the team. Ashton Harris, right next to her. Most of you know, maybe your supervisor. And then Marcy Bartula is a new supervisor for Brazos County, and we're excited to see her. And of course, Sarah is sitting next to her. Sarah is a CASA volunteer. But I didn't want to leave anybody out at the table. So this is Judy Swenson. Judy is a registered nurse as well as a CASA volunteer. She has great experience to share with you about drug-exposed babies and the symptoms and what we need to be looking for as we do medical advocacy for these kids, even up through as they grow up, not just when they're babies. So with no further ado, I'll turn it over to Judy. Thank you for being here, Judy.
I had a choice, right? Just to give you a little background, I've had ICU, public health, pediatric, quality, and multiple other experiences. And I've had all 3 of the babies that I've taken care of have all been drug-related babies, and I understand every time I went to court, there was almost every single case was a mom that was addicted or using. So it is a very bad situation, but it's growing and it's going to continue to increase, especially with the legalization of marijuana, or K2, and I'll talk about that a little bit later. I'm also very selfish. I only gave you 2 handouts, but I want you to know that you will get a copy of all of the slides, and you will get, I've worked up some charts based on different drugs and some of the things that can happen to your child from birth on to adulthood. And my goal is, as I add to this, like there's no inhalants in this, and if I do a new chart, I'll make it available to Kate and she can put it out so that you can add it to your list of drugs that you'll have. If you have questions, please feel free to ask, unless I say right now's not a good time because we're leading from one thing to another. So let's get started. And I can't promise it's going to take an hour. I've gone through this so many times. I can do it fast, I can do it slow, but it's based on y'all as well. All right. We are going to look at neonatal abstinence syndrome. Kate.
Okay.
Oh, okay, sorry. Is it not going forward? I think we might have turned it off. Let me see. You can, there it is. You may have to point, I may have told you incorrectly. You may have to point it right at the,
Which one now?
oh, I'm sorry. It's the one on the right. Uh-huh. Let's try it. Yep.
All right. So the class objectives for this course in the class itself are to define neonatal abstinence syndrome. You're going to list 5 symptoms displayed by NAS babies. That's just the abbreviation that's used. Verbalize at least 5 drugs most commonly used in our community. Utilize class charts, which you also will get when we're down to that point. And describe common effects of infants and toddlers if mothers use these drugs. We're going to utilize those class charts to describe probable or possible long-term effects on the children of addicted mothers of these drugs. And we'll list at least 4 observations you all as volunteers can make before or during the visits to your infant or child. And hopefully this will help you become more aware of what the things are that you should be looking for. So, at birth, the baby's, what actually is neonatal abstinence syndrome? At birth, hold on. It's a group of conditions caused when a baby withdraws from certain drugs he or she is exposed to in the womb before birth. It's caused when a woman takes opioids or other drugs during pregnancy, causing drug dependence and addiction in the mother and fetus. So that's why the neonatal abstinence syndrome comes into effect. It's because the fetus becomes addicted as well. At birth, the baby's dependence on whatever substance it was or polysubstance it was continues, but the drug's no longer available, so the baby starts going through withdrawal. And it depends on many factors, and we're going to talk about those. When that drug is no longer available, the central nervous system, which controls a lot of the things in your body, both controlled and automatic things. Respiratory is automatic. You don't have to say breathe, breathe, breathe all of the time. It's an automatic response. And it comes from the brain. So it's overstimulated and it causes those symptoms of withdrawal. And we're going to talk about the symptoms of withdrawal. All right? The lack of the drug also affects the autonomic system, that automatic breathing, your heart, etc., and the GI tract. And in the GI tract, they may develop vomiting, poor feeding, etc. Right? It may involve an initial phase that is short but intense. I missed that one. And some of those things that can happen to the child when they're first born, and you do have a chart that gives you the time frames based on the drug of when this may occur. And it can occur as soon as the baby is born up to 48, 72 hours later. All right? So the baby may have tremors, seizures. They're very irritable. This is very, very common with a drug-addicted child or baby. They have feeding problems, vomiting, diarrhea, hyperthermia, increased fever, and other systemic signs that can last up to 2 weeks. Those initial ones based on the drugs themselves. And not every drug is going to do all of these, but every drug that the mother has used has some effect, which we may not see until later in life. After the initial phase, the following can occur. You have hyperirritability. This may be when you see the baby. They get out of the hospital, you pick them up, and they're a couple of weeks or a month. They're hyper-irritable. Right? They have sleep disturbances. They have hyperphagia, which means that hyper means high, and phagia means eating or disorder. They may vomit here. They just have other symptoms, loose stools, and then they can have neuroscience and the automatic that can last for a few weeks up to a few months. All right, so they may have diarrhea, they may lose weight, and then have a feeding problem. If they're very irritable and they're very active because they're irritable, they burn up a lot of calories. So they're going to need a higher caloric intake. The drugs that can cause neonatal abstinence syndrome, these are just a few. And as I go through, if there's more, we'll change this chart so that it'll make it available to you. Codeine, hydrocodone, which is Vicodin, morphine, oxycodone or Oxycontin, Percocet, and some of these you know by the brand name, and some are generic names. So if you're not sure, go back and look it up. You know, the net is great for looking things up, but the net can give false information. For instance, the mom that I have right now is attention deficit. And she was on amphetamines, and when she became pregnant, the doctor took her off. Well, then she got, she was vomiting and nauseated all the time, so she went into the net and she found that marijuana is something that can cause nausea to be decreased, so she started taking K2, and we'll talk about K2 later. Well, K2 is marijuana. It's a chemical marijuana, and so she put her child at risk, because marijuana, they said there's nothing wrong with marijuana. We'll wait until we get to marijuana, all right? That's not true. The incident, so then there's heroin, tramadol. I think that's kind of funny, because that's what the vet gives your dog or cat for treatment. Heroin, fentanyl, there was in Ohio. Fentanyl was mixed with marijuana because it's a chemical, K2. And people in the park in Ohio were watching all the people that were smoking marijuana at the time pass out. Some of them died in the park. There was a total of 24 people in the park that day because fentanyl was mixed with the marijuana. Okay. Methadone, I can't pronounce this, you can read it. Hydromorphone, methamphetamines, and amphetamines, they kind of group those together, and then codeine. But you can also look at antidepressants. Nicotine is being more and more researched, and I've run into things, so you're going to get a thing on nicotine when I get that one done. Benzodiazepines, which are sleeping pills, and alcohol. And y'all know about, or y'all are familiar with the term fetal alcohol syndrome. Well, fetal alcohol, in my initial study, I just eliminated because there's so much in that you need a separate class or a separate chart on that, and that would be another topic. And then marijuana or K2 in very high doses. The incident has steadily increased. Every hour in America, an infant is born with neonatal absent. Can you tell I'm a little nervous here? Neonatal abstinence syndrome. That means 10,000 babies are born every year with NAS. And we're seeing it. Every time you go to court, you see something, right? And you don't think of it in this term. Come on. How's it diagnosed? Let me make sure. Okay, these are some of the characteristic signs and symptoms. Tremors or twitching, irritability, excessive crying. You're going to get a copy of all these slides, all right? So you don't have to memorize this. Tachypnea is fast breathing. Okay, tachy and nypnea is breathing. High-pitched crying, fussiness, sleep disturbances, hyperactive reflexes. You know when the dog hits your knee and it jumps? Well, this baby's going to really jump, okay? Hypertonic muscle tone, they're tight muscles, skin excoriation, feeding difficulties, GI disturbances, vomiting, and loose stools. They may also exhibit sweating, sneezing, fever, or unstable temperature. That means they may be fine and have a normal temperature one time and you take it and the next time it's up and then it's down and then it's up, or it stays up for a while and then it goes down again. Nasal stuffiness, yawning, and dehydration. There's a condition that's called failure to thrive. And I don't know if y'all know about that, but a failure to thrive baby is one that you try and you try everything. The doctors try everything, the nurses try everything, and that baby may die just because they're a failure to thrive. They can't digest, they can't breathe right, and no matter what you do, they die. That is a potential for some of these children. They're small for gestational age in many of the different drugs that are listed. They're respiratory complications. They have abnormal EEGs, which is brain waves, or seizure activity. And with a lot of these, there's an increased risk of sudden infant death. So that is something that if the parents are not aware of, it may be something that you need to be sure and look up and know that they shouldn't be laying on their stomach. They should be laying on their back, a little bit elevated. Just look that up and make sure that the parent's aware that that is a potential with some of these conditions. Symptoms can begin 24 to 48 hours after birth or as late as 5 to 10 days. Well, let's just say the baby didn't exhibit any symptoms while they were in the hospital, and you get to see that baby at 10 days and you're seeing some of these things, this baby is going into NASS, and probably you need to call the doctor or have this baby brought back to the hospital because the baby now is at risk. But if you don't know what you're looking for, or don't even, you know, when you make a visit, when we're going to talk about that a little bit later, what can you do? When you make a visit, you evaluate the child. Do you really look at the child? You know, we can see and we can look. It's important that you look, but that you see that child as well, from the top to the bottom. And if your gut tells you, like I just came back and talked to Marcy about a thing with mine, that it's just a gut feeling, so you need to pursue it. Okay? Don't let it drop. Come back to the supervisor, talk to the supervisor, and steps will be taken so that we can determine, is this truly going on, or is it something that because of the circumstances of your visit showed up and it's just because of the circumstances of the visit. Some symptoms may last as long as 4 to 6 months. So if the baby goes home and we're going to talk about how you can determine or what you should do, and you're there 4 months later and you're seeing something that's really weird as far as some of these symptoms, you need to follow up on it. Don't let that baby go because it can get worse instead of better. And whoever's taking care of that baby needs to be aware that they need to watch for certain things, or you need to watch for certain things, or they need to go back to the doctor and get double checked. How's it diagnosed? First of all, you hope to get an accurate record from your mother. And it has to do with the time, the type, etc. that the mom used. Now, how accurate do you think your mom's record is of the drugs that they've been taking? So even though you try, it's probably not going to be the truth. If they say they're taking, you know, marijuana, or they're using marijuana, they're probably using something else, because if they can't get that, they need the high on some other drug. Same thing with cocaine. They'll take whatever they can get if they can't get their drug of choice. So always question, is that really true? Some people it may be, you know, but the majority of what we're seeing probably is not true. The second thing is a neonatal scoring system, and you have a copy of that. It's the Finnegan system. What happens when the baby's born, if they're showing any signs while they're in the hospital, the baby may go to ICU, or they're on the in the regular nursery. And the nurses every 2 hours will throughout the day score this child. And if the child reaches a certain score, then the physician's notified, and the child may be put on drugs, and we'll talk about that in a minute. Okay, because remember, they're having withdrawal symptoms because they don't have the drug in their system. If a person who is addicted needs a high, they go out and buy more drugs. Well, this baby can't. So we've got to take care of this baby in the hospital. So the nurses will do this, and if their score is high, the baby will probably go on a drug. And then it's gradually weaned down until the withdrawal symptoms are gone and the baby's body is acclimated. The second thing, and so that's, you know, it's one thing to say a Finnegan test, but if you read down this, not now. If you read down this, it's pretty detailed, and there's a certain score, and we'll talk about that. The second, or the third thing are lab tests. The Meconian test is the baby's first bowel movement, and it detects from about 20 weeks of gestation. It's a better test than the urine. So it goes back to 20 weeks of gestation, and it'll show whether it's a positive or a negative. If you look at the Meconian test on a medical record of that child, and the child is positive, you'll see a high and a report. If you see a high, not only is that meconium had drug in it, but it's got a lot of drug in it. Because the lab will write an H or an L next to your lab studies. And if you see that, then you need to be aware that this kid was really addicted pretty heavily for maybe as much as 20 weeks. Okay? Questions so far? Yes?
Right. Do they or do they not drug test every mother who gives birth in the hospital?
I don't know. Can't answer that.
Because I believe that they did it now.
I don't know.
You don't know?
I really don't. Sorry. I can call St. Joe's and ask them if they do.
Yeah. Well, I know a lot of hospitals do, but I just wondered if it was like across the board.
I
they do.
don't know.
Okay.
All right.
So,
You had.
yeah, question, I guess kind of along that same lines, then how, they don't necessarily test every baby's meconium for drug
For drugs,
exposure,
well, remember,
correct?
we're looking at reports of mother's addiction or possible addiction, right? That's the first thing.
Okay,
So I would say that any mom that comes in and says she has used, et cetera,
then
or they have a suspicion, they're gonna check her.
Okay.
And if they know that the mom has been using, CPS is probably called. Okay, how is it treated? Based on that NAS score, the baby may receive medication. If the mom was addicted to codeine, then the baby's going to get an opiate of some kind because it's in the same drug family. You can't give marijuana to relieve opiate symptoms, all right? So the baby is going to get a drug from the same family and to manage those withdrawal symptoms. The drugs become smaller and smaller as the baby withdrawal symptoms lessen and the baby's body then gets used to the fact that there's no drug anymore, right? And the drugs may include methadone. Methadone, when I looked it up, and you'll see on the chart, it's a good drug, but it's a bad drug. Morphine, y'all know, and one of the things with morphine is respiratory depression, so they have to be careful in how much they're giving. And then buprenorphine, I guess it is. That's a good drug, bad drug. It's on the charts you're going to get. Right? They also need IV fluids to prevent dehydration because they may be vomiting, diarrhea, or they're not feeding well. So they need the IV fluids during that time. IV fluids also help to wash out the system of some of those drugs. Okay? And the baby's screaming, yelling, irritable, very active. You know, they're flailing sometimes. And we'll talk about what to do with that. They need a high calorie formula for those feeding problems. They can have a slow growth and increased activity. The child that I have right now has some GI problems and has trouble feeding and was losing weight. So he's on a high calorie diet now, and it was started at every 2 hours and then 3 hours, night and day, to give him a high calorie formula, and now he's on demand. And he's doing better and he's gained weight. So that's the progression that we're looking for, is to be sure. And before he went home from the hospital, he was gaining and then he lost, which is kind of typical of babies, but he lost more than he should have. So those are things to look for, you know, are they losing weight or are they gaining? And it's not just up to the doctors. Talk with the foster parents or whoever that child is with. Are they still gaining? Are you having trouble feeding? Those are things that are important for you to know, to bring back, to talk to the supervisor, and then do something about if you need to. Okay? Questions? Some of the long-term outcomes, there are several studies that report behavioral problems and developmental problems. ADHD, ADD, hyperactivity. There's a thing that's called ODD, and that is beyond ADHD. They can get violent and, you know, so the gamut can get from not so bad to really, really bad. Specific long-term problems, otitis media are ear infections. And there are a few drugs that is very well known to happen. Well, that doesn't sound so bad because my kids both had ear problems and we had to put tubes in. But if we don't catch this and the child's not medicated for it, then they can have language difficulties because they can't hear. They can have speech difficulties, again, because they can't hear. And it's not always blamed on what's happening where they eat or talk or whatever. It can be because they can't hear you. All right? Motor developmental problems, behavioral and cognitive problems. They have trouble in school. They have trouble organizing. I'll use my son as an example. We adopted him at birth, and I didn't know anything about the mom, but I firmly believe that my son was addicted when he was born. Okay? He has attention deficit. He went through suicidal thoughts and ideation. He went through depression in later years, and you'll see with some of these drugs, that's pretty normal. He's fine now. I mean, he was on medication. He took himself off when he was in junior high, and then he uses it now if he's doing something that he really has to concentrate for, but he hasn't taken his amphetamines in, I don't know, I think 6 months now, so, and he's 31, so he's doing good. So just because these kids have this doesn't mean that it's a death sentence or, you know, they're not going to make anything of their lives. That's not true. The big thing is to get the treatment and to keep following through on that treatment to be sure that they get what they need. We talked about the risk of SIDS. There is a greater risk of future drug use with children or babies that have been addicted. And child abuse and neglect also can occur. And there is a chart I'm going to give you about that. But basically, if this child goes home, whether he's adopted or whether he goes home, all of these things that you see can precipitate child abuse because the parents don't know how to deal with them. You know, and if they're screaming and yelling, and Mike went through a period where he was violent, and you know, you get to the point where you want to tear your hair out. You don't, but that's what happens. And then the child is neglected. So then they become that person that's back out there getting drugs again. So it's a vicious cycle that I firmly believe that each one of you has the power to stop. Okay? Psychosis, and this was new to me. Psychosis, can't talk. Psychosis can also be drug-induced, and the drugs that do that are alcohol, cocaine, hallucinogens, and marijuana. Because their chemistry changed, and they have the genetic biochemistry in their system from mom and dad, and then there's the stress. And these kids, later on in life, panic. They don't usually do well in school. Math is always a problem for most of them, so you know that right away. So if you have an older child and they're having trouble with math, they may need some help from the school. What can we do? The first and foremost thing that you need to do is once you're assigned a case, you get into that record and you read that record and you find out, I don't care if the child is 6 or 16, you need to know, was this child exposed to drugs before the child was taken or has been exposed to drugs during, in the womb. You need to read that because you need to go back then and look at some of the charts and look at this class and see if that child is exhibiting some of those symptoms later on in life, because it can carry through, right? Check the doctor's report if there is one. Review the long-term effects, which you'll have. Talk about SIDS if this is a baby that's just going home. Remind parents that that's a possibility because of the drugs before, so they're observant and that they watch. Not to panic them, but just, you know, SIDS is out there, and you don't want them to feel guilty that maybe something happened and they caused it. So if they're aware, then that would help. If you have a baby that's very irritable or uncomfortable and is crying, swaddle that baby snugly in a blanket and hold that baby. Make sure that the room is quiet and dimly lit. Any stimulation will cause it to start all over again once you get the child relaxed. And this kangaroo the baby is skin-to-skin contact. Have the baby just have a diaper on, and you have that baby to the mom's chest, the dad's chest. The skin-to-skin helps to relax the baby. And so that would help that infant or child. And it doesn't matter. I mean, a child could be 5 years old and they just losing it. And if you can get them and just hold them, you may not wrap them, but just hold them to you or hold them to the mom, that helps to diffuse. All right? Yes?
Okay, the situation, the baby's born and it's definite that he's an ass baby. He's not going to go home with mom. CPS is going to step in. So he's either going to go to a foster family or possibly a kinship foster
Right.
family.
Right.
Is CPS educating the foster parents on this stuff if they just give them a baby and say, go? I mean, I don't know what the foster parents are told.
I don't know that
Yeah, that's-
either, but
Well, most non-related foster parents go through extensive training. And I'm gonna assume part of the training is this, you would hope. And we have one CASA volunteer who's gone through some foster parent training just to find out what's going on. So we'll try to give you more information about that. And then kinship placement, unless they go and get licensed, I don't think they get much information at all. That would be my assumption.
So we have to be far more vigilant, I would think, with the kinship
well,
placement.
I think you need to be vigilant with everyone.
Yes.
Find out what they have been taught, find out what they do know, and then fill in the pieces without getting them all hyper and upset, because then, you know, they're going to be a nervous wreck. This baby already may have some problems with irritability, and babies feel what you're feeling. They know if you're uptight, they know if you're angry, and they react to that just like you do. So that's why it's really good and really important that you keep calm, talk in soft voices, keep the room down. Now, that's not 24/7. That's when the child is really upset. Otherwise, the child needs to be treated just like any other child that you're out there looking at and taking care of. I think I might have covered all of this. Really look at that baby or child. Okay? And I was telling Kate about this. When I did education for hospital, I used to dress out like a patient and put all of the, you know, tape an IV to my arm and a tube to my mouth and oxygen and the whole bit, you know, a urinary catheter taped to my leg. And the nursing staff, every single one of them, had to go through and they had 2 minutes to write down, and there were 15 things that they should do, okay? 2 minutes to go in and observe. That's really looking at that child, or in this case, that quote patient. And to come out, write down everything they saw. Do you know who saw most? Was the nursing assistants, not the RNs, not the LVNs, not the doctors that participated. The nursing assistant who was there doing blood pressures and everything else. So an example, therefore, is the nurses were there only looking at the IVs, at whether they're putting out urine, not looking at the patient. So I encourage you to really look at that child, at that baby. Every time you go, really look at them. Pay attention to how they walk. These are motor skills. How they walk, how they talk. Do they follow in directions? Can they play? Do they play with other people? These are all observations that you can make very simply by looking at that child. Watch for signs of eye problems. Look at their height and weight, or ask about their height and weight, and see if they are gaining like they should, or are they getting obese because the family's letting them eat everything, right? Watch for the hyperactivity. Some of the things, going back to Mike, he could not sit at a table and eat. He was up and down, up, Mike, sit down, up again, okay? That's just a perfect example. Give them a snack and see if they can sit there forever, you know? If they can't do that, then you need to just watch them. Don't make a guess on one time. Do it again and again, and then you'll really see, Some kids you can actually pick it up. Oh my gosh, this child is just really hyper all of the time. And the foster parents and the parents will tell you the same thing. Okay? Yes?
I have a question. Okay, so say the mother is not really digesting the drug, but she is in a household where they're doing meth, they're smoking marijuana. Does that impact the baby too? I mean, I'm just
Well,
trying
there's
to,
not,
like secondhand smoke or whatever.
in all of my research, and I spent a lot of times because I was working this for a case to start with, I did not see anything about that
Okay.
directly,
Okay.
nothing.
Okay.
But that doesn't mean it doesn't happen, especially, I did not go into nicotine, and I told you that's one I will go into and get you the charts for. And they are showing that that may be a problem with nicotine.
Okay.
But I don't want to say yes without the facts to
Well,
say
okay,
yes.
if
Really
Marcy, you can correct me, but when we were in our family planning, they wanted to drug test the kids because they had been around
The smoke or
or meth or.
Yeah, and generally meth homes, they'll, I mean, if it's constant, I mean, that's why we
Okay.
believe that that one child may have, was it our case that had a positive? No, the case before, I'm sorry.
But I just.
I do have a case where a child did have a positive screen for meth because he was in the home. He didn't, we don't believe that he ingested any of it, it's just because it was just in his face all the time. And it's, I mean, I think it's possible, it's with meth at least, for sure.
I had a case yesterday where the 4-year-old was positive for meth and the 2-year-old was positive for meth and heroin.
And
I
you
was gonna
read
ask that
almost
same question.
every day on the net about kids that found the stash and took it. You know, it's scary. So we just need to be really, really conscientious. When you go in a home, it's not just the kids you're looking at. You should be looking at the home too, you know. All right, C, besides the hyperactivity, is this child impulsive? Do they have a short attention span? Ask them to color a picture, and if they can't stay there in picture at least, or color part of it, and they're up and down again, take that into account, you know, look for things. Because you're evaluating what this child is doing in a home that he may have been before and was getting back to his mom and dad, and maybe they're using undercover, you know. Check for school absences in the school-age child, school failure, or other behavioral problems that the school is having. And that may be the last one. That's it for now. All right. Now I'll be nice and give you the handouts.
Would you like some help? You go.
Yeah.
I'll take that and you take that.
These are the slides.
I made 20, so if I don't have enough, let me know. You have some more, do you?
We'll probably have to get some more.
Okay.
Because
I
that's
want to keep
what
one for you. You're thinking I might, oh, thank you. I'll make some more also. You have one?
And the second thing I'm giving you, and it's in alphabetical order, not specific, because if I was really going to talk about things, it would probably be the cocaine. She's gonna make some more of that. Oh, y'all have, how many need that?
Like she just has one. Did you know that?
Someone need this?
And I'm making some more also.
I have one more drugs.
Anybody needs more handout? My stewardess ways.
All right, what I tried to do with these, as far as the drugs are concerned, is to take the drug, and you'll notice that if the literature, and I have a list of who I got, all of the sources that I took this from, if you all are interested. If there were specific ages or groups of ages, then it's noted here. Right? If they're not specific by age group, I tried to clump them into infant and toddlers, and then into adolescents, and then into adults, so that you have a pretty good picture of what the drug does initially and what it does later on in life. So, I don't think, you can read as well as I can, and I think you'll get more out of reading this than me going through it step by step, unless you want to do that. But if you'll go to the last, I assume that that's, you'll read it yourselves. Go to the last page. And the last page actually lists some of the most common lasting effects from the drugs. Now, please remember that every drug doesn't exhibit the same way, but there are things that are very common with almost all of the drugs. So what I tried to do was to list some of those things here. And so common side effects with prenatal exposure. The first is low birth weight, smaller head circumference, behavioral issues, and cognitive delays. That is almost every drug out there. Now that doesn't mean that your child is going to have those effects. It just means it's a potential for that child. And one of the things that I found very interesting in talking about opiates, they've become more and more popular in the community and in the United States. But it's not new. In 1875, the first child or infant was noted as having opiate withdrawal in 1875. So it's been around a long time. The only thing is we didn't know how to treat it, and most of those children or babies died. So it's been here, it's just gotten worse and worse and worse. All right, so there is the increased risk of SIDS, there's hyperactivity, ADD, ADHD, impulsive. They have distorted thought patterns, poor parenting interactions, poor self-esteem and sense of worth, heightened sensitivity to drug triggers, which means there's a future risk of drug addiction in the child. And we talked about child abuse and neglect. So I think that's about all that I can share with you at this time, unless you have other questions. Yes.
I just have something to say. Gates are just before my former next door neighbors were foster parents and had been for a long time here in Texas and in Arkansas. But they had when they were living in Tennessee, they had a baby that was who was born. And they were foster caring it, and the baby was about 2 weeks old when they got her, and now they did everything that you said. I don't know if I know they had a job before in Arkansas that had problems, but that child for 6 months, that baby cried day and night, would not sleep. It was, and I was right next door, and I was over there all the time, and it was really, it was awful. Elizabeth nearly went out of her mind, and so did their kids and all, but somebody always held the child, and Elizabeth always wrapped her, around her when we went out. But now the jaw got much better, and we were very pleased. She would smile and laugh, and then the mother wanted the jaw back, and they let her have her, and we don't know, of course, what happened because she was out of the county by then. She had moved to another county. But my friend, my neighbor, tried to check on her, and the caseworker said, you don't want to know. And so, I mean, we were just, it took them about it. You know, they never got over it because it was the thought that we don't know what happened to that little child.
It's devastating.
Oh, it was really devastating.
And going back to Michael, you know, I was stupid when we got him, as far as how to treat and so on was concerned. And I remember, you know, we always had the dark room because that I was trying to put him to sleep. But I remember, you know how you rock babies? Well, I couldn't rock baby Michael like this, and I would hold him and I'd have to rock him like this. And then he would calm down. He would not calm down with just the subtle rock. And cry all the time. I mean, you know, and I'm not saying this bad, but it gets to the point where you understand some of child abuse because they push you. And I remember many a time putting Mike in his crib, going out, closing the door because I was at that point where they're going to lose it, you know. But the right person doesn't lose it. Some people do. And one of the babies that I had at the pediatric hospital, one of my mini horses is named after her mother's boyfriend took her by the legs and slammed her against the wall. And she came to us unconscious in the hospital. She had been in Jefferson Davis at that time, and then came to us at Healthbridge. And she was right across from my office, and she used to call me Mom when she finally woke up and started talking. That child was resilient. And by the time she left, after about 2 months or 2.5 months, she was up walking, talking, telling the nurses, no, I don't want that, I want this. You know, just because they're really, really bad, they are resilient, they can take a lot. I will say that both the mom and the boyfriend were in jail, and the father was on his way to Afghanistan, and they pulled him back. And she went with the father's sister until he came home from the war. So, you know, good things can happen, and you're a step in between there to try and make that happen. I think that's all I have.
Thank you.
Thank you. All right, well, thank you very much. Any last minute questions or anything? That was great, Judy. Thank you. Now, Judy will be presenting another CASA Cafe in November about the effects of different drugs on children. So we'll send out a reminder, but what she wants is for you to send her the names of medications, and not just street drugs, but medications. Is that right?
Whatever
you're
like
interested
in.
in.
What I'll do is, if I get too many, I'll pick out the most common ones. And I'm going to try and get my friend who's a pharmacist back in Houston to try and come and do it. I can't promise, otherwise she'll get me again.
So be on the lookout for that email. So that's it. Have some cookies. There's more food. More salad. Eat more salad. We always buy too much.